Testing 1, 2, 3. Testing 3, 2, 1.
Testing 2-6 stream. Testing 2-6 stream.
come together. We know this is a huge season of change. In so many ways, we're coming out of the wilderness. And we know there's going to be a whole new landscape, new outlook, new opportunities for growth and change. And so we ask, Holy One, that you open our eyes to all the possibilities, open our minds to collective wisdom, and open our hearts always to and for the communities we serve. What a privilege and an honor it is to be where we are in this moment of time. Bless the work that is before us. Bless everyone who's here, and bless all we serve. In your holy name we pray. Amen. To the flag of the United States of America, and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
Any citizens to address the board?
No citizens at this time, Mr. Chair.
Okay. Next thing on the agenda is the Roman numeral 4 is the approval of the minutes. Board of Managers, May 13th, 2021, and I'd entertain a motion to approve.
Move for approval.
I'll second.
Discussion, anybody? All in favor, please say aye.
Aye.
Those opposed, say no. Motion passes. Board Chair report. I have three things that in the future I would like to do, but I'm not going to do it today. Today is still thank you for everybody that, do what? Yeah, the gloves are off next time, man. But I think there's a couple things that we should have, and that's the things that are of some community interest and any type of legislative update. And then one thing that you'll see different on your minutes is the foundation board will now be a standing item for presentation and review. And once again, thank you to all that have done so much for so many things. I mean, I can't even start. Okay, Robert?
Thank you, Mr. Chair. Wanted to give you all an update. You have the profile of Dr. Becker at your seats. Dr. Becker was brought to JPS through a national search through the Hearts search firm. We were very impressed with Dr. Becker. Dr. Becker has 30 years of experience, you can see, in healthcare. He is a nephrologist. His wife is a transplant surgeon. He is just a really talented person. And I think both Dorothy and I in the interview process and many others that interviewed him were impressed with his sort of methodical nature. And he really came shining through as a very strong candidate for becoming the president of Acclaim. So we offered the position to him as the president of Acclaim, and I'm happy to tell you he has accepted that position. Dr. Weber was very pleased with his interview, and Dr. Hurd and others who had the opportunity to meet with him. He received accolades from everybody who met him, and I think he's going to be quite an advantage to JPS. He has history, and you all will meet him as soon as he gets here. He'll be coming July 12th. And we'll have him before the board to discuss Acclaim and where we're going and what we're doing, and working with Dorothy, obviously, as the current chair, and dealing with that process. But I will tell you at this point, his business skills, his medical skills are a really nice combination. So we're all really pleased that Dr. Becker will be joining us.
Oh, yeah, I agree.
So, and for those of you who are involved in the interview process, particularly the board members, we thank you all very much. We realize that that's a challenge. I would speak to one other issue in Dr. Becker, and that is the reason that we found Dr. Becker is we have discovered in our last 5 searches that Mike Hart's search firm has been getting us strong candidates and strong national candidates that we've not necessarily had the opportunity to see. And we've been very impressed with his vetting process. So to that point, we've asked the Mike Hart's search firm to also do the search for our compliance and auditing and risk management position. And he is doing the national search. He recently provided us 3 candidates amongst about 25 candidates. He brought it down to 3 candidates, and we've started that interview process. We had Mr. Fisher and Ms. DuBose and Chairman Weber interviewing those candidates. We as staff interviewed those candidates, and we'll see how that process goes. But we've done the preliminary interviews at this point, and again, they were candidates. All 3 of those candidates happened to be external candidates. We did not have an internal applicant, but they came from, one of the candidates is, well, they're all from different parts of the country. And so that's been a huge benefit to us, I think, to reach out to candidates that we had not normally necessarily seen. So the Hart's group is doing a very good job, at least in their searches for us, and we're very pleased with them. Wanted to give you a bit of an update on the legislative process. For those of you that watch the legislature, you will be happy to know that for those of you who might have family members that are in the legislature, you'll be happy to know that they're coming home. So you will have to change your ways, Mr. Powell.
He's not smiling.
You will have to act differently around the house now, because I think...
Charlie, you need to pray for a special session.
Well, he doesn't have to pray hard, because that's one of our updates. There will be a special session. And the debate right now is to when that special session will be called, and it's anybody's guess. If you're a betting person, you might be looking at the end of July. You might be looking at the beginning of August for a special session. It will be a challenging session, because they'll primarily be dealing with a couple of the issues they didn't finish during the session, but more importantly, they'll be dealing with redistricting. And another name for redistricting is bloodshed and war. So those are really, really challenging times for legislative bodies, especially in a state like Texas, where you'll be getting additional congressional seats, and you'll be reapportioning just for your old level of 7th grade Texas history. Texas has a capped amount of state senators and a capped amount of state representatives. So we have 31 and 150. So when the state of Texas grows, you don't grow the number of state representatives or state senators. You just apportion it differently for the amount of people that they represent. So what that means is there's oftentimes pairings of legislators that are currently holding 2 different districts now meshed into one. And what you look at in the state is you look at where your population changes are happening, and you provide more seats in the highly populated areas, and you reduce the seats in your less populated areas. That, as you can imagine, is a nasty place to be, and I've been through that process.
Robert, you've been through that.
Yeah.
You just mentioned something based on the current population. A senator now will have 1 million constituents.
Yes.
They'll have, a state senator most likely will have more constituents than the United States Congress.
Yes, and in maybe 1 or 2 states more than a U.S. senator. So it is a challenging time, and you'll be hearing a lot about that. For us, I will come back to y'all next board meeting and give you a little bit of more of an update on the legislative wins. And the reason is because there were allocations that increased behavioral health in the legislative process. Kudos to both houses. The Senate and the House did a really good job of understanding the need for behavioral health and changes in behavioral health from a funding standpoint and initiatives. We'll see if JPS has any possibility of tapping any of those initiatives, and I don't want to go through that. Those, as Mr. Montgomery and Mr. Powell and Mr. Petty and those who have dealt with the legislative process know that when pieces of legislation like that of magnitude pass, it has a large dollar amount, but you're not quite sure how it's going to be distributed and where it's going to go. So we have to sort of look through that from a behavioral health side and go through that process. Budget-wise, I think the state of Texas found itself in a much better place than it thought it was going to before the session. There was aspects of a potential, $75 billion shortfall, and none of that took place. So I think things righted itself a little bit better for the legislation that passed. It did get a little, unfortunately, contentious at the end, and I know a lot of bills did not pass because the Senate and the House were in a bit of a fighting match, and that happens often, but I think this time it happened at a little higher level, and I think more pieces of legislation, depending on your view of legislation, more pieces ended up dead towards the end than usual, but that is the process sometimes. I think you had new House leadership, you had a new speaker. My understanding is the speaker was very fair, did well with his committee assignments, and conducted a good House process. I know a little bit less about the Senate and its process, but they didn't have changes in the Senate and their leadership, so I think they're accustomed to what the Senate is and how it's acting. I think everybody's kind of watching the House and how it did, and the speaker did a very, very good job. The speaker is from the Beaumont area and seemed to bring a lot of that sort of true East Texas way to him in a good manner. So that went well. The session for us was good. There is a state senator by the name of Powell, Beverly Powell, and it rings a bell.
Cowbell?
Senator Powell and State Representative Guerin passed a very powerful piece of legislation for JPS. It was House Bill 2847. And what 2847 will allow, and it was just signed by the governor, so we're not stipulating on whether it would be signed or held up. You're in the process now, which every legislator fears. You're in the period of vetoes. And you think that life is great and everything is passed and all your colleagues and all the fighting is over, and then you get this strange notice that the governor just vetoed your bill. And it usually comes oftentimes out of nowhere. You're blissfully at home telling your constituents all the great things you passed, and you get a notice from the governor's office. It's never from the governor, it's always from the office, and it's almost like a pink slip that comes to your house and it just buckles your knees. But this bill 2847 allows JPS to be able to obtain, retain, and profit from its own intellectual property. So when we look at research and we look at the findings of those research, we can provide partnerships with private sector, and we can gain from that research, both not only from the medical advancement of it, but for any profitability that there might be. And profitability for JPS means the opportunity for more people to get services. Because for JPS, it's not a bottom line issue, it's a what do we give back to patients issue. So I'll break that down a little bit more for you, and I'll actually get copies of the bill for you if you want them. But Melissa Acosta and our team in the research department, Rohit, and the team in research did an incredible job. Melissa went down and testified, and both Representative Guerin and Senator Powell would oftentimes need quick snippets of information to deal with their colleagues on particularly something of intellectual property that maybe you're trying to figure out, okay, what's the ramifications of that? But it passed, and we're very proud of that. And we will definitely honor both the senator and the state rep, but if you happen to see the senator before we do, which there's a chance of, if you would thank her very much, we appreciate it. It was a nice piece of legislation for JPS.
I'll just say one thing, and again, we joke about this, I don't get in her world in the Senate, she didn't get in my world in the banking business, but I will tell you that it was very personal for her. Staff in this hospital did a tremendous job in support of that, to be quite frank, so they have a lot to be commended, but it was personal, because we discussed in this board, look around this board table, and Amanda, maybe in the last few years, but several's been on this board for 10, 12 years, we always talk, her DT, who's not here today, talk about research. We talk about research, what we're going to do. So hopefully this will open up avenues to put us on the playing field in the future as we do reach out. So again, not just with our, I'm here to say that not just with the senator, but at the end of the day, with her and obviously Representative Guerin and the whole group of staff did a tremendous job.
Yeah, when next board meeting, we'll have Melissa Acosta come, and she testified before numerous committees, and I think did an excellent job of saving that. There was a couple questions at various times, and there was a slowdown at various times, and we weren't sure whether that was going to come out of the funnel the way we wanted it to come out of the funnel, and it worked really well. So very proud of the JPS team and very proud of the Senate and the state rep that made that happen. So that's sort of my report, Mr. Chair. If you would like for me to, I will go right into the next report, which is the next thing up, or any comments or questions anybody has. Okay?
Should we invite the new mayor and Senator Powell and whatnot to just thank them?
I think what we'll do, we would be happy to do that, but we would probably bring in all the new mayors of the county, not just the mayor of Fort Worth, but all the new mayors. We will be happy to at least make them an invitation to come to JPS.
Just say hello.
You bet. We'll be happy to do that. So that's really all I have to say about Mr. Wynn and what he's been doing for us. Oh. Let me go into the next bit. Well, I'll tell you, as I articulated, he's been spectacular. What I want to do is each board meeting, we bring you a clinical and a non-clinical area of JPS to get a little bit of a better understanding. And once again, I'm happy to see Roderick in the audience from Commissioner Brooks's office, because you see JPS as our citizens can see us, and you see us from the outside, but just attending this, you get a little more information about some of the things that we do and the intricacies of what we do, because there's obviously a whole lot more to the fabric of JPS than what might be in an article here or there, or a comment here or there, and to your constituents. So I think what we're going to do is we're going to bring up Dr. Jerry Henderson. Dr. Henderson, you all have met in the past, but I will give you just a brief history of Dr. Henderson. The first thing we need to do is thank Dr. Henderson's parents, because they live in Tarrant County, and that's really a main reason to bring him back to Tarrant County, because Dr. Henderson, being the principled individual that he is, had a family member who was challenged with cancer. And at that time, he was in a very formidable stage of his medical education, was going through the process of trying to figure out what he did with his medical education. And that family member, challenged with cancer, allowed Jerry to be a part of the MD Anderson team in Houston. And Jerry spent a good deal of his time trying to help out those in the greatest of need, battling the difficult battle of cancer. And so Jerry spent a good deal of his career at MD Anderson, and then there was a need to have him come back and spend a little more time with his family in Tarrant County, and that opened up the perfect timing for Jerry being open to looking at Tarrant County opportunities and JPS having an opportunity. So for us to be able to bring Jerry Henderson on board was a huge benefit. He is a huge talent to us. And he is, I think, like Dr. Becker and Dr. Miller, those kind of rare folks that can bridge that gap between what you need to do administratively and still being a clinician and still giving day-to-day care to our patients and being an administrator. So Dr. Henderson's going to tell you about our clinical informations and our analytics, because there's some neat stuff going in there. The last thing I'll say is it is tough to restrict our executives to keeping their remarks somewhat limited in these areas, because they are genuinely excited about what they do, and I appreciate that very much. But what Dr. Henderson wants to do is give you all, board members, those listening to live streaming, and others in the audience like Roderick, an idea of what goes on in the analytics, the area that you head up. So Dr. Henderson, thank you for being part of this team, and it is now all yours.
All right, thank you, Robert. Thanks for that wonderful introduction. So, and good afternoon, ladies and gentlemen. I just was asked to come and give you an update of my department, and that is the Office of the Chief Medical Information Officer. Because this is the first time for me to address the board here, I just wanted to kind of give you an overview of what that is. And the Chief Medical Information Officer is really the strategic and tactical leader for clinical systems across the enterprise. And as the current arrangement is that I report up to the Chief Operating Officer, I think that's an optimal arrangement, because the Chief Operating Officer is really where the rubber meets the road and where all the planning and really all the action happens. The JPS analytics team reports up to me, and that is a recent kind of change since January. I collaborate across the organization because my team is quite small, so I matrix very well across the different teams, and I love to help out wherever I can. But that's sort of my MO, is collaboration across the network. So let me just tell you a little bit about data analytics team. So we currently have 13 individuals on that team, and a lot of their responsibility lies in partnering around quality and outcomes. When I say quality, I don't really mean the quality department. Some of those things are things that are externally reported outside of our organization, but many of those things are internal quality outcomes. Those are things in departments, and we work a lot with those individuals. We support data-driven decision-making, which is a very, very interesting thing when you start injecting data into conversations. The conversation changes a lot, and it's very interesting how that happens. We provide insights really across the entire spectrum of leadership, and what I mean by that is not only the executive team, which sometimes happens, but many times to middle management. And why we believe that that's important is because middle managers do the day-to-day decision-driven activities of this organization. That's really what makes the organization run. And so we take a great pride in that, in partnering with those individuals. This is what the structure of the JPS analytics team. I know it looks a little bit like a hierarchy, but we function in a very fluid sort of a manner, and it is. We have the axiom there that our excellence is really about people, and it's not about software. Sometimes when you think about analytics, you start thinking about the software, but it's really the people that make the difference. We have an amazing amount of talent here. This is a very internally competitive team, meaning that they're always trying to be better. We have outstanding leadership. Our executive director of Physician Enterprise, Kendra Honeycutt, comes with a lot of business experience, real-world for-profit business experience. Our director of data analytics, Tim Muirhide, which recently joined our organization, came over from Cook's, and he brings a lot of data analytics talent from their payer program, from their health care program that they have there. And so those types of things really enrich the environment in which this analytics teams run. Many of our collaborative partners across the organization, I would say these are the top ones that we collaborate with. The Chief Technology Officer, obviously David Mendenhall, we work a lot with his team on various things. Telehealth is one of them. IT reporting, Sajid Sheikh is a constant companion of mine when we're doing reporting and we're doing dashboards. I talk to him almost every single day. His team is outstanding as well. The EHR team, we have updates probably 2 to 3 times a year, as well as daily fixes and breaks. I work very closely with that team as well as the provider liaisons. The provider liaisons, for some of you who don't know who they are our interface with our providers on the EHR. And so they have a lot of knowledge about what goes on the front lines and what are the problems and what's working well and what's needed. And so I interface with them almost on a daily basis and depend on them quite to some depth. The finance team, we have worked with them on some data around cost analysis, that's accounting costs. And with quality, we continue to work with them on data integrity, things around quality, especially with external reporting. And then infection prevention, we recently built order sets in order to meet their objectives of antibiotic stewardship around certain illnesses. And pharmacy, we recently completed almost a year-long project, I'd say, around therapeutic duplication, which is really pretty much state-of-the-art. And we worked very closely with them on that. Patient experience, Laura is, we're working with her team in order to build dashboards, but most recently, we're partnering up with her new provider experience team that she'll soon be putting together to tackle provider champions and to create a new group of provider champions across the network to support EHR education and physician engagement.
Who will be doing that, Jerry?
So that's to be named yet. So that's going to be Laura's team. It's going to be her executive director, so she's onboarding shortly. So this is just an example of one of the products that we've collaborated on and produced together. This is the one that we worked really intensively with the reporting team, with Sajid Sheikh and his team. This COVID-19 dashboard was absolutely critical during the pandemic at shoring up operations on a day-to-day basis. There was a lot of concern early on because resources, you can imagine, masks, gowns, gloves, ventilators, particularly medications, rooms, all of these things were in limited supply, and being able to manage those things on a day-to-day basis became utmost importance to this group. We built this out really rapidly and continued to build on it, and it turned out to be the centerpiece, really, of our team that managed the pandemic. The COVID-19 Command Center really was driven upon this, and so I can't say enough to Sajid and his team, the way we worked on this and built this together. If there was an award for a COVID-19 dashboard, this would probably win it. It's really impressive. Some other work that we did around this is the COVID-19 care flow diagram, which shows how patients flow through our system. This is a Sankey diagram that on the right-hand side you can pull out certain payer groups, and you can see how those COVID patients flowed through our organization at different levels of care and what the outcomes were. This is going to be very interesting, I think, especially after the pandemic, when we reflect back upon it and look and see what happened. Well, the 40,000 total, right, that were tested. Yes, sir.
DT,
Yes.
couldn't hear you.
Yes, sir. So I think the question was, are we tracking patients through inpatient when they're admitted and discharged through discharge?
Right, or are we still tracking them because we don't know what happened to them in the next few years? And
Oh, yes, sir. So yes, and I'm not an expert in that area, but there is a post-COVID team that does monitor those patients and follows up. So Dr. Stephen Davis, I believe, heads up that team, and they're doing quite a bit of research around that.
so we may be able to see the long-term effect. In the
Right, exactly. That's exactly what it is. You may recall this, we worked with finance and Whitney on this particular project. They supplied the data, and we provided the data visualization. What it shows is actually of all of our connections patients. These are the locations of the top 10% of cost, which is cost that's an accounting cost, so that's cost to us. And so you can see how those different areas within across the county, you start to see certain hotspots, which might be areas to look at moving healthcare resources upstream to see if we can avoid those additional costs. And so this is the way you can navigate through this environment. You can see the different areas. So on telehealth front, when I first joined the organization, right at the beginning of December of 2019, I had a plan of rolling out telehealth, David and I, within the first 12 months, which we thought was pretty aggressive. It turned out that we rolled it out in about 3 weeks. As soon as the pandemic hit in March, we had really no choice but to roll this out rapidly. The technology was obviously just a small part of this, but it was like the providers really went above and beyond to make this happen. You can see that by the end of the 4th week, we're up to about 1,600 visits a day. And so really impressive. I think that says a lot about the people that work here and about our health network. This is a dashboard that was created by the analytics team. So Joshua Manning's one of our senior data architects, phenomenal talent around creating dashboards. And this particular dashboard, there's a lot of ability to dive down and to start dig deeping into the data. One of the things that's kind of interesting that we first noticed about this is that our no-show rate for telehealth patients was actually quite low. It was about 10%. And when you compare that to in-person visits, which are about 25 to 30%, you start wondering if maybe there might be a good strategy to mitigate some of those no-shows by introducing telehealth to some of those high-risk visits. And so just one of the things that we kind of noticed from this.
Yeah, and one thing about that is last year we looked at telehealth during the budget. I know budget is coming up, and what I know that I would be looking at is how that telehealth increase would be affected.
Right, and the financial part of that is something that we're still struggling to figure out how to optimally operationalize that to make sure that it works well for us and for the patients. Oncology express lanes. Previously, Robert mentioned that I had worked with MD Anderson Cancer Center. We had hired consultants to come in to make our oncologists more efficient. One of the main things they rolled out were these oncology express lanes. And first thing I did when I got here is we rolled these out to our oncology infusion center for their oncologists, and they like it a lot. It's basically for patients that have very predictable visits. They can, basically everything is lined up for them, and so they can zoom right through the visit. It also works well for other chronic conditions, so we'd be exploring that next. I don't know how many of you are aware of this, but about a year ago, almost all of our consents were paper consents, and there are a couple of issues with that, and one of which is that from the time that you complete the consent to the time that it's actually scanned and shows up in the EHR, there's a kind of a blackout period, and then those paper documents can also be lost. And then it's hard to keep track of which ones were signed and which ones weren't. One of our specialists for EHR integration, Nicole Farrar, has taken upon herself to create a lot of expertise in this area, and she has become the regional expert in electronic consents. One of the actually outside organizations now reach out to her for help on this. We have almost achieved 100% of our consents electronic as of this time. And what that allows us to do is not only to adequately track those consents and account for those consents, they appear instantly in the chart, but also it allows us to be able to account for those in the storyboard, so clinicians can easily see, the EHR can easily see if consents have been signed or not, to account for those. It's through a separate system. I mean,
DT, turn your mic on.
It might not help.
I know, but just for the fun of it.
No, I'm just curious if we start tracking the medical devices and all that stuff, so that we can tell if there's defects, malfunction, or heart, pacemaker when they have batteries runs out, or.
So we do, yes, sir. So we do track all of implants that's tracked inside Epic. As far as the actual device manufacturer name and model, I'd have to follow up with you on that for pacemakers, particularly. Yes, sir, and that's important for MRIs and for compatibilities. I'll follow up with you.
Thank you for turning your mic on, DT.
And
There you go. That might be the best.
so within a few weeks, Nicole's is rolling out mobile consenting as well, and this is absolutely key for certain areas. We're doing remote behavioral health work and programs like T-Chat to be able to consent patients remotely, and so this is absolutely key. So amazing work there. So some of the things that are currently, I'm not going to go through this in detail, but these are some of our current projects that we're working on at the current period in time. We really want to enhance data governance to the point that we make self-service reporting much more efficient and effective and scalable. I mentioned before, we're rolling out that JPS Provider Champion Network, which is going to really help with EHR education and provider engagement. We're doing remote patient monitoring. We recently found a vendor for remote patient monitoring, which is going to allow us to be much more scalable in that program, which is currently very successful, but it's limited because we're just depending on human resources for that right now. electronic wound measurement is something that is going to allow us to measure wounds much more efficiently and effectively and accurately and be able to track them across encounters, which is really important for our clinicians. And we're also exploring a business analytics collaboration with TCU right now through their academic program. And we're putting a project request for a multidisciplinary tumor board for our oncologists.
Awesome.
And that is all I have. Happy to take questions.
Jerry, let me ask you a question, because I was fascinated by that COVID-19 care flow diagram. If I'm reading that correctly, the largest sector of payers within that diagram was commercial patients.
I'd have to go back and look at that, but that's
2,986.
entirely possible. Yes, sir.
So here's my thought. If 2,986 commercial patients came to JPS for COVID testing, how many of those did we ask whether or not they had a primary care physician? And is that an opportunity to bring more commercial payers into our community clinics under our population health metric and try to manage more of that patient? Because I've got a feeling that's not an anomaly. I've got a feeling there's a whole lot of people now that, because of JPS clinics and JPS access points and all the work that we've done, that the opportunity to collect more commercial payers, which allows us a much healthier revenue stream to pull those people into our system, this looks like evidence to me that says that opportunity's there. And I just wonder if that's something that we should be thinking about in terms of how we harvest that group of patients.
There's a couple responses to that. One of the things, before Jerry responds from the analytics side, is I think the simple answer to that is yes, in that more people are becoming accustomed to the services that are offered at JPS, our process, our system, our clinics. The other thing is, to Mark Hallman and the Innovation Office, of trying to look at not only what we can do from within JPS, but what do we do with existing partners? What kind of partnership might we create with Baylor Scott & White? What might we create with HCA? And I think if you take Mark's position as Chief Innovation Officer, and you take Dr. Becker, who will probably bring some really interesting concepts to a claim, I think you're right in line with exactly with what you're talking about. So now, from an analytics standpoint, Jerry, you may want to add more to that, but I think the next 2 to 3 years future of that trend is very strong.
Yes, sir, and we'd be happy to look into that as a business opportunity. We could do dedicated work around that to try to evaluate the possibility of that.
I think it's a great opportunity for us. We're probably going to be building 4 new community care clinics.
Right.
We're going to have the largest presence of the entire healthcare network for JPS in Tarrant County over the next 10 years. Will be easier to get to, faster to get to, with higher quality service and faster response than most other healthcare systems. I mean, if we're gonna put the investment into that and spend $1 billion in facilities to make sure that that's all there, everything we can do to bring more commercial patients and create access. And I'm not even thinking that this results in us taking patients from others. I think this is just that group of patients that don't have primary care physicians that need it, that give us the chance to say, you know what, JPS can be your provider. So this is fascinating information. I'm glad to see it.
Chairman, I agree with you. I think the other thing we're forgetting is just how many people are moving here from other parts of the country. You know, I think sometimes we think about JPS in the past. The current staff and management is creating a whole new, I'm not saying image, we've always been a great institution, but think how many people are moving here. They don't have that what was. They want good health care provided, convenient, and if we give them that access, I think you're exactly right. I think more commercial patients will come out.
For me, it's more like the expansion of the JPS connection, because we provide that for that population of the county. Now we can go back to the employee group type thing for direct contract for
Even somebody not sophisticated as I am with all this stuff, I just used telemedicine during the COVID. It was fantastic. Prescription was delivered. I mean, everything was.
I think we can test that with the president of the bank. The bank.
Could you go back? Okay. Could you go back to the interactive map that you went through real fast? I mean, I just kind of want to see it one more time as you interacted, you know, made it for us to be able to see.
Yes, ma'am. So this is
Yeah.
just a video, but this is navigable on the application.
Okay, all right.
So you can see the different columns there are different clinics. Well, at the time this was built, those were existing clinics, and the blue lines are showing the amount of cost in that location. So you can see downtown, there's a huge amount of cost, and what that's associated with is those homeless shelters.
Okay.
If you actually drill down into that.
Okay,
So
all right,
there's
thanks.
a lot of opportunity there. Thank you.
Two things. I will say that Dr. Henderson has brought an element to JPS that I think has been needed at JPS. I think to DT and Dorothy and Amanda and Zim and some of your questions that you all have had about where are we going with connection. Jerry is beginning to back up the analytics to being able to ask from staff what we should be doing from an expenditure standpoint, but then you as board in what policies you should direct us into. So I look very much forward to the future and what Jerry's doing. The other thing that I wanted to say is I know it's been a year and a month since we've been in here, but there are a few on live streaming asking you all if you will turn on your mic and bring it closer to you so that our live streaming audience can hear us. So thank you. And I'm not going to thank anybody else, Mr. Montgomery.
Thank you.
Well, I just wanted to say thank you for this information. This is the kind of information that I love seeing, just because I'm a data wonk and I really need to. I really am impressed with this care flow chart. I think we need to do that across the board. And what I'd like to see also is a patient experience journey map. I think that one of the things that we really need to concentrate is what that beginning flow, especially when I'm looking at into Trent's point, commercial is the largest, but when I think about the connection program and self-pay, I think of those together because that's almost the same population. And so we have to look at what that larger percentage is and the way that they're flowing in and out and where they're going through as many outpatient or throughout the, okay, so thank you.
Thank you.
I expect more of these kind of dashboards. Just saying it.
Okay.
Thank you.
Thank you.
Gary, good work.
Thank you.
Okay. Next thing I have is Roman numeral 8, report from the Medical Staff Executive Committee requiring discussion, deliberation, action. Cheryl.
Thank you, Dr. Chair. If I may be indulged for just a few seconds to give my usual verbal report that I got used to giving, just to say about the medical staff quality oversight functions. We did approve the PSI 90-May report at MEC last week, as well as the minutes of the PSQG that were submitted from January through April. And we had our usual report from Dr. Elliott for our academic affairs, as well as Ms. Dent came as the Vice President and Chief Nursing Officer to give the CNO report to us. Thank you for coming. And in addition, we approved our user minutes. We also have a tentative date set for further education and training for the MedExec Committee on peer review, protection, and privileging for July the 29th, if we can get it all arranged. Now for the big thing is the bylaws that I've been giving you brief updates on. I'm really excited. So May 18th, I had an opportunity with the Bylaws Committee Chair, Dr. Haynes, as well as our consultant, Erin Mullenberg from the Pulsinelli Group to hold town halls for the medical staff so that they had an opportunity to ask us questions. And we held our general staff meeting on May the 25th with well more than the quorum that we needed. And the actual medical staff approved the bylaws by 98%. So we were super excited. And as a result of the hard work of our committee, Dr. Miles, my vice president, and myself, in conjunction with our own legal consultant who had been in contact with general counsel here, we basically took months' worth of effort. We combined multiple documents into one. We had several, and there is included in your board portal, not just the bylaws, but an executive summary for you all that kind of goes by the kind of high-level overview of the changes. But we combined several documents into one. We added some membership opportunities, so something like an administrative. So like, for instance, a Dr. Duncan could now be a member if she wanted to, because we have an administrative membership as well as community affiliate, which helps with our research. And we did some other things to do some additions and make some revisions. But I think the thing that's most elegant that I'm really the most proud of is And definitely the help with our legal experts is there are footnotes at the end of each page that cite Joint Commission regulations, conditions of participation for CMS, as well as applicable local Texas law. I'm happy to entertain any questions.
A lot of work.
It is a huge amount of work, and to you, Cheryl, and the team, I mean, y'all, I've been through a couple of these with med staff, and the last time, I mean, it was like building pyramids, and you all did an excellent job of connecting your legal staff with our legal staff and going through the process, so thank you.
Thank you.
Cheryl, how often does this need to take place?
Well, this was an overview of combining all the stuff since 2010, but there have been some revisions that had occurred over the years, and what we discovered when we had separate documents for 4 different manuals is there discrepancies developed because we focused on just one manual and didn't map it back to the other, so then they were in conflict with each other. So now that we've done this big overhaul, the Bylaws Committee is being tasked with making this a living document, and they will be reviewing and revising on an annual basis. Not this big of a project, but definitely keeping it much more up-to-date, much more modern. If new departments need to come in or that have been developed, because we suddenly got a whole group of things here, then that'll be brought in as well. So the Bylaws Committee is going to be much more active.
Thank you.
Any other comments, questions for Cheryl? I have one legal question that that Daphne and I'll talk in closed session. Other than that, we good?
Is your question going to hold up a vote on the item?
No, it will not hold up a vote.
Okay.
In fact, if there's no more discussion, entertain a motion to approve and a second.
Move approval.
Second.
Discussion, anybody? All in favor, please say aye.
Aye.
Those opposed say no. All right.
Thank you.
Passes. Very good, Cheryl. Next is Roman numeral 9, other matters requiring board discussion. First is policy PC 200, pain management. There's Ms. Dina.
Good afternoon. I'm asking the board, requesting to consider approval for policy PC 200. That is our pain management policy. What we did for this policy, and you can see the red lines, we updated our requirements and updated the reference list. So I am requesting approval for policy PC 200, please.
Anybody? Entertain a motion to approve. And a
Move
second.
approval.
Second by DT. Discussion by anybody? All in favor, please say aye.
Aye.
Those opposed say no. Motion passes. Next is RI 2500 abortion service. Dina.
Thank you. Second policy is RI 2500 abortion services. Red lines are updated in your packet. What we did was update our definitions, and under guidelines, we updated our physician's documentation requirements, requesting to the board to consider approval of RI 2500, please.
Any discussion by anybody?
Move to approve.
Second.
Discussion? All in favor, please say aye. Those opposed say no. Motion passes.
Thank you.
Next is the,
Mr. Chairman, you can
pull that one off.
You can call on me. I'm going to ask that we take this off the agenda today, and I'll tell you why. What we're going to do is, we really would like to allow what you all approved last time, is the recognition of the chair of the board and the chair of the planning committee, of the committee that's going to get together to look at the issues. We want to give you all the opportunity to look at,
God bless.
we're going to look at all the opportunities to look at the RFP process, the protocols and the policies behind them. How did we get to that point? And the committee really wants to establish the rules of those protocols, the guidelines, but that committee is not designed to serve as the decision-making body at all. It's to resolve any issues, to vet issues, to bring them before there, so that when it does get to you as board members, you all will know, one, it's had a set of eyes on it, It's asked those preliminary questions that need to be asked, and it'll go forward. So what we're going to establish through that group is the master schedule, the data for supporting the RFP, what the RFP is intended to do, and how that process will work, so that when it comes to the board level, all those issues will be vetted. And so when Reverend Emerson has a question, or Amanda might say, well, was this, did it go to this community? What, do we have it in multiple languages? Those kind of issues that many of you validly have, those will all be vetted. So it was, I think, too soon to bring this up. We are still ahead of schedule. Derek Walls is with us in the audience from Broadus, and I will tell you that Broadus's involvement in this and Karen Duncan's involvement with Broadus on this has been hugely helpful. And just in the last 2 weeks alone, I think we've made great progress. I've had that communication with our Commissioner's Court. I had that conversation, Roderick, with your boss about the restructure that we were trying to do, so that we can go through this process in a very transparent and a detailed way. The other thing, so that we stop any potential rumors, the next meeting of the committee is going to be on the 18th. I will not be able to attend that meeting, and that's probably a good thing, but I didn't want anybody to say, why is Early not here? I'm going to do something I've never done before. I am now a licensed preacher in the state of Minnesota, and I'm actually marrying 2 people who have asked me if I would marry them. It's a young lady that worked with us, and she has no family. So I'm going to Minnesota, and I'm going to marry them, and I cannot postpone their marriage for the JPS committee. So I apologize. So I didn't want everybody to say, where's Early and what's up? Because there is a sensitivity to everything that's regarding bond, and I don't want it to be there. Yes.
Well, the point of order was.
There is a point of order.
Point of order was, I was asking head of HR committees, would she, that's okay, that's not an extra job.
No.
You're underneath current existing policy.
It is under current policy,
Good.
and I am not paid to do this. And I will unfortunately be flying to Minnesota because we have too many JPS responsibilities.
If the marriage doesn't work, we're not liable anyway, are we?
No,
Okay.
I may be, but JPS will not be.
All
So I think we're good.
Point of
So
reference taken care of.
I know it's a long-winded part of why we're pulling it down, but I think it's important for you all and the streaming audience to know that we weren't pulling this down because there's trouble or there's challenges or anything else. We're pulling it down so that we have the best information to bring before that committee, and that committee will be in a much better position to bring that information to the board. So, Mr. Chair, that's why we're pulling it down.
Yeah, it's a communication tool.
Yes, sir.
No question. It's not a deliberation, make decision committee.
Yes.
Okay.
Okay. Thank you all very much.
You're flying up and flying back.
Yeah.
Okay, next thing I have is committee reports. Roman numeral 10, first is Finance Committee.
Mr. Chairman, on the 27th, we had a Finance Committee met. It was another one of those really, really special meetings. I mean, people are still talking about it. I mean, right here today, I'm still talking about it. We
Sharon just whacked herself in the head.
I think his leadership is really kind of what separates him from, So we so we considered.
We just got a live stream call that said, "Turn off your mic."
Turn off your
Actually,
mic.
it's the first time we've ever heard that.
Ever, yeah. So we had we reviewed the April financials, which are doing great. Ms. Clark is here if you have any questions. I think most everyone here was in attendance of the committee, that fantastic committee meeting. We also did a policy on our depository and an amendment, or we revised our policy on that. And we also put forward several contracts in addition to some professional services agreements and some great work that Zelia did on behavioral health with the local school districts. So we put them forward for the full board's consideration.
Good. Questions for Steve? Anybody? Okay, next I have is B, Human Resources.
Yes, we met on May the 27th, and I think our meeting was a little bit faster than the financial committee. But that meeting, we did beat you on the timing. But at that meeting, we looked at a couple of departments that had high turnover, and they had focused on that. The HR department had focused on that and really had reduced the turnover for those couple of departments. And hopefully, it was dietary, which is really high, and I can't think of the other one. But they had focused on that and had reduced that turnover almost by over 50%. So that was really good. And we have some policies in the packet for approval. That's my report.
Okay, questions for Dorothy? Anybody? Next I have is Planning Committee.
Yes, sir. Thank you, Mr. Chairman. We met, as you know, I think everyone in the room was at that meeting. Primarily, we looked at our existing capital project reports. Angie reported on the status of those that we've been tracking for the last several months, and we put out a format that illustrates how we're going to differentiate the capital projects of JPS from the bond projects of JPS, and went through a process to illustrate what those protocols look like. Broadus was at the meeting, so they will also be at the steering committee meeting to make sure that we're following that protocol. And as you suggested earlier, Robert and Chuck both, our hope is that once the committee begins working, we're able to put forth a very consistent and logical, trackable protocol for all of these steps, so that there will be a time period that this stuff is made available on the portal. The board will all see it. The board will have an opportunity to comment on it. Then it will be put forth to the entire board for any discussion or committee. So a lot of our effort is going to be facilitating that process to make sure that it's clear and trackable for everyone.
Okay, anybody questions for Trent? The Quality Committee met on June 3rd, Thursday, 2021. We had the usual COVID-19 update, and we had the PSI 90, which is the quality scorecard, and continued to look good. I mean, it's unbelievable. The folks are doing a damn good job at taking care of patients. And then we had one presentation on the patients with delirium, a new project that's underway, and sounded pretty good. The delirium is for you and I, Zim. Just
Why do you keep joining me?
You're my younger brother. Okay. Okay, anybody got any questions for me? Now, we need to do anything with these? No action or anything? Okay. Next thing I have is a consent agenda, and entertain a motion to approve, and if there's anybody who wants to yank one that we need to discuss, please do it.
Mr. Chairman, I'd recommend we pull item 8, I believe, H, right, Robert? Is that the, was that the agreement on the RFP, or was that, which one of these had to do with the action related to RFP? Was that the only step?
Yeah, the only one that did was the one we pulled off the actual calendar. All the consent items are not related to that issue.
Perfect.
You bet.
I'll make a motion to approve.
Okay, is there a second?
Second.
Discussion for any of them? All in favor, please say aye. Those opposed, say no. Next thing I have is report of legal counsel and/or legal matters requiring discussion.
As you recall, Mr. Chairman, my report is now going to be quarterly unless there's something out of the ordinary that needs to come forward to the board. I do have an item for closed session.
Okay.
Thank you. I know it was heavily negotiated, but I appreciate being invited.
Lordy, the respect we give people. Okay, well, that's all that I have for open session, so I'd like to reconvene in executive session. You guys want to take, you guys, sorry, Amanda, Dorothy, Cheryl. Take a 5-minute break?
Yes.
Okay. 14:05. reconvene in open session for deliberation and/or action. We have two things. One is privileges. Cheryl, would you like to?
Thank you, Dr. Chair. We just
Dr. Chair.
request a motion for approval of the privileging packet as presented in closed session.
Discussion for anybody? Entertain.
Dr. Chair,
Second.
You got them, Suzanne?
you got 3 seconds.
Second.
All in favor, please say aye.
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 Those opposed, same sign.
Okay.
We have one other item. Dorothy, you have
Aye,
the...
okay. I make a motion to ratify the authority from the Board of Managers to proceed with the resolution of the quarantine litigation as requested.
Second.
All right.
Discussion, anybody?
Dr. Chair.
Huh?
Dr. Chair.
All in favor, please say aye.
Aye.
Those opposed, say no. I've got no other thing except one little sentence I'd like to say to all of you. And then we're out of here.
Yes, sir.
Okay?
I'm pensive, go ahead.
Are you ready?
I think.
No. May you find love in your life, and may you find joy in each day and peace at night.
Yeah, that's wonderful. That is very nice.
And we're now adjourned.
That's right. Dr. Chair,
Yes, sir.
I know the chair